Popping and gapping, the chiropractic dance. Most chiropractors depend on a signal of success with manipulation, the audible pop or crack. Patients often too have the same expectation and are curious as to the explanation of what causes this sound. Much has been investigated, theorized, and debated about this indicator, and much has been learned. We'll use a recent publication and some past publications to review what is the current knowledge on this topic. The questions are rather obvious. What causes this sound? In other words, what is it doing? Is it helpful or harmful? And is it necessary? Generally, there are three suggested causes of the pop or crack that result from manipulation: cavitation, which we will focus on, snapping of ligaments and tendons, and breaking up of intra- and extra-articular adhesions. Let's start with cavitation. Cavitation was first described by Unsworth in 1971 using the metacarpal phalangeal joint. Since then, there have been a plethora of publications related to this topic, searching for ways to measure the effect. Simply for the expediency of time, I'll discuss only a limited number of these articles, but the listener should further research the topic to find articles by Triano, Kowchuk, and Pearl, among others. Cavitation is the process of cavity formation in a fluid when subjected to negative pressure that surpasses the vapor pressure of that liquid. In essence, cavitation is the process of gas bubble formation. In more depth, when pressure is reduced in a film of synovial fluid between joint surfaces, gases are released from the synovial fluid during a phased transformation from liquid to vapor. Rapidly, a cavity forms and collapses, and a sound is created. The gas bubble then returns to ambient pressure and is believed to maintain that for approximately 20 minutes, then is thought to dissolve back into the synovial fluid. The sequence of cavitation is first a rapid increase in joint volume caused by the manipulative maneuver, which drops partial pressure of CO2 and nitrogen within synovial fluid. These are released as gaseous bubbles into the joint space, producing the popping sound. It has been proposed that a change in intra-articular pressure occurs as a result of manipulation. The normal negative intra-articular pressure is now closer to atmospheric pressure due to the presence of the intra-articular gas bubbles, which could result in a decrease of the net filtration rate of synovial fluid into the articular cavity, with less synovial fluid being produced and more being drained. It is also proposed that cavitation of the synovial fluid is determined by the viscosity of the synovial fluid, the state of the joint at the time of the manipulation, the relative laxity of the periarticular ligaments, and the velocity of the manipulation. Well, let's focus on viscosity and velocity. When articular surfaces move rapidly, synovial fluid has a low viscosity. Conversely, when there is slow movement at articular surfaces, synovial fluid has a high viscosity. This principle has been called Thixotrophism, which states that the viscosity is inversely proportional to joint velocity or rate of shear. The lower the viscosity of a fluid, the less force is needed to cause cavitation of that fluid. This changing viscosity with changing rate of shear is due to hyaluronic acid in the synovial fluid. Other concepts related to viscosity include temperature and sustained load. A decrease in temperature of synovial fluid results in a higher viscosity, and an increase in temperature results in lower viscosity, facilitating easier manipulation. Sustained loading increases the viscosity of the synovial fluid so that the joint cavitates more easily and/or earlier in the joint's range of motion, partially because there is less fluid in the joint after sustained loading. Interestingly, another concept is that for inflamed joints, neutrophils produce lytic enzymes which interfere with hyaluronic acid protein complex formation, and the viscosity of the synovial fluid is substantially decreased, which theoretically would make manipulation easier. Prior to reviewing a more recent publication from 2014, let's briefly review past studies on cavitation. Using plain film radiography, several authors have been able to demonstrate a radiolucent space in the metacarpal phalangeal joint after cavitation with an axial distraction force. The radiolucency is thought to represent gas bubbles. Computed tomography and radiography have been used in an attempt to demonstrate gas bubbles in the cervical spine facet joints after manipulation. However, one study reported that no post-manipulation gas bubbles were visualized with or without traction. MRI has demonstrated gapping, but no search for cavitation bubbles. Now to a recent publication entitled Ultrasound Imaging of the Trapeziometacarpal Articular Cavity to Investigate the Presence of Intra-Articular Gas Bubbles After Chiropractic Manipulation, published in JMPT in 2014. This study is unique in that the researchers used high-resolution diagnostic ultrasound. The purpose of the investigation was to visualize cavitation gas bubbles in the trapeziometacarpal joint after chiropractic manipulation, and monitor and visualize the state of the gas bubbles after a 20-minute refractory period using high-resolution ultrasound. There was a total of 20 participants. On the screening exam, the trapeziometacarpal joint was palpated and high-velocity, low-amplitude manipulation was performed. Only those participants with an audible cavitation were included for the imaging consultation. This narrowed the participants down to those that the researchers would be able to manipulate with confidence during the imaging visit. Among the findings were the presence of microcavities in synovial fluid. Microcavities were present in 5 TMC joints and were approximately 1/10 the size of the post-manipulation cavities. These may have been formed during the manipulation at the screening consultation and had not yet entirely dissolved back into synovial fluid at the time of the imaging. However, their significance is unknown. In fact, there was no noticeable difference between joints with or without pre-existing microcavities with regard to the ease with which the joint cavitated. The work of previous authors suggests that a joint with a pre-existing gas bubble will not cavitate, but perhaps the size of the bubbles in this case were significant. Other findings of this study were that in 13 of the 18 post-refractory ultrasound scans, gas bubbles were still visible at 20 minutes post-manipulation. Participants could have had a longer refractory period than suggested by prior authors, who reported a maximum of 22 minutes and a minimum of 17 minutes before joints could be cavitated again. On average, in one study, a 68-minute period was necessary before a second set of cavitations was obtained from the facet joints of the lumbar spine. Some of the author's propositions are that cavitation shifts the physiologic equilibrium of the joint by reducing synovial fluid production and increasing synovial fluid drainage. Range of motion increases after manipulation may be due to the presence of intraarticular gas bubbles that may result in greater joint capsular volume, with a resultant increase in articular surface separation. Let's now look at some aspects related to when and where cavitation occurs with manipulation. The early studies began in the 1990s and used various approaches to measurement. One of the first was by Herzog et al., entitled Cavitation Sounds During Spinal Manipulative Treatments, published in JMPT in 1993. Specifically, they measured instantaneous acceleration signals obtained from the spinous process of T3 during SMT and the practitioner's perception if cavitation had occurred or not at the end of each treatment. It appeared that cavitation may be measured during SMT using accelerometry, and not surprisingly, that a practitioner's perception of the occurrence of cavitation during SMT is very accurate. The next step was measuring the ability to determine location and then whether manipulation was specific to the intended segments. One study focused on these areas of interest in a spine publication in 2004 entitled Determining Cavitation Location During Lumbar and Thoracic Spinal Manipulation. Is spinal manipulation accurate and specific? The purpose and design was to locate the joints that produce an audible sound in response to manipulation and compare practitioners' perception of location for accuracy using 64 asymptomatic individuals and 28 clinicians. Accelerometers were applied to the skin over the spinal column, and the relative time at which each accelerometer detected vibration from the cavitation associated with the manipulation was used to calculate the source of the vibration. The results were interesting and frustrating for some. The average error in distance from the intended target of 124 cavitations in lumbar adjustments was 5.29 centimeters, at least one vertebra away from the segmental contact. Of 124 cavitations, 57 were deemed to be accurate and 67 were deemed to be inaccurate. Even the accuracy was in question because multiple cavitations occurred, which included the intended segmental contact. Specifically in the lumbar spine, SMT was accurate about half the time, and most manipulations produced multiple cavitations. A more recent publication evaluated whether the intended side and intended segment was isolated to the cavitation sound. The title was Bilateral and Multiple Cavitation Sounds During Upper Cervical Thrust Manipulation, published in BMC Musculoskeletal Disorders in 2013. Arguing against specificity, they found bilateral popping sounds were detected in 34 of 37 manipulations, while unilateral popping sounds were detected in only 3 manipulations. Of the 132 total cavitations, 72 occurred ipsilateral and 60 occurred contralateral at the intended C1-C2 articulation. Therefore, statistically, cavitation was no more likely to occur on the ipsilateral than the contralateral side. And finally, as to the effect of cavitation on outcomes, 2 main studies stand out with regard to an effect on pain and disability. Both are by Flynn et al. The presence of cavitation did not seem to affect patient outcomes in these small studies. One important feature of these 2 studies is that the manipulations were performed by physical therapists, not chiropractors. Now, let's mind the gap. One feature important to the concept of cavitation or breaking of intra-articular adhesions is gapping the joint. There are a number of interesting recent studies, all by Cramer et al., targeting this area. One of the first high-level studies was by Cramer et al., published in Spine in 2002, entitled The Effects of Side Posture Positioning and Spinal Adjusting on the Lumbar Z-Joints, a randomized controlled trial with 64 subjects. These 64 volunteers were asymptomatic. The researchers studied both the setup position for side posture adjusting in addition to the actual adjusting itself, measured using MRI. The SMT used was a resisted mammillary push technique. The researchers' conclusions were that, quote, spinal adjusting produced increased separation or gapping of the Z-joints, and that side posture positioning also produced gapping, but less than that seen with lumbar side posture adjusting, unquote. Next, quantification of cavitation and gapping of lumbar Z-joints during spinal manipulative therapy, published in 2012 in JMPT. They found that upside joints gapped more than downside joints with either SMT or side posture positioning. Upside joints gapped more in men than in women. Cavitated joints gapped more than those that did not. Cavitation indicated that a joint had gapped, but not how much a joint had gapped, and that SMT resulted in greater gapping than side posture positioning alone. And finally, in 2013, in JMPT, magnetic resonance imaging zygapophyseal joint space changes in low back pain patients following spinal manipulation and side posture positioning, a randomized controlled mechanisms trial with blinding. This was a complicated crossover design with 4 protocol groups. Patients were included only if they were Category 1 based on the Quebec Task Force, meaning no radiation or suspected disc involvement. Subjects received 2 weeks of care between 2 MRI appointments tagged M1 and M2. The SMT was a resisted mammillary push technique. Other treatments were allowed, including hot moist packs, ultrasound, and/or interferential nerve stimulation. However, only SMT was provided during the MRI appointments. Here are the 4 groups. Protocol 1 was the side posture positioning group with neutral positioning followed by side posture positioning, remaining in side posture positioning for the second MRI exam. Protocol 2 was the SMT control with neutral positioning followed by side posture positioning spinal manipulative therapy followed by neutral positioning for the second MRI. Protocol 3 was the SMT group with neutral positioning followed by side posture SMT, and remaining in side posture for the second MRI, and then Protocol 4, which is the side posture positioning control, with neutral positioning followed by brief SPP, followed by neutral positioning for the second MRI. And here they are graphically in sequence. The crossover design involved the following. The M2 appointment was identical to the M1 appointment, with one exception. Each subject was assigned to the protocol group opposite the one to which he or she was randomized at the M1 appointment. For example, M1 Protocol 1 was assigned to M2 Protocol 2 and vice versa. This way, during the study, all subjects were in both an intervention and control group, and all subjects were in a side posture positioning and SMT group. Interestingly, for the Protocol 3 group, which was SMT followed by side posture positioning, it was the only protocol group to show significant improvement in pain, whereas those subjects receiving side posture SMT and then placed on their backs, which was Protocol 2, had almost no change in pain following the intervention. The researchers suggest that perhaps lumbar side posture positioning may have a therapeutic benefit with acute low back pain, increasing gapping in patients with acute pain and enhancing pain reduction following SMT. The increased gapping that occurred with prolonged side posture positioning, which lasted approximately 12 minutes, could conceivably promote the breakup of intra-articular Z-joint adhesions. SMT followed by side posture positioning may also reduce pain by stimulating mechanoreceptors in the Z-joint capsules and paraspinal muscles. The researchers conclude that side posture positioning showed the greatest gapping at baseline. After 2 weeks, SMT resulted in greater gapping. In other words, it increased over time. And side posture positioning appeared to have additive therapeutic benefit to SMT. Whether gapping with cavitation actually is breaking up adhesions, it's important to remind the listener of a monumental study by Cramer et al. That is likely relevant to this question from a basic science perspective. It's entitled Zygapophyseal Joint Adhesion After Induced Hypomobility, published in JMPT in 2010. Without going into the complicated study design, the researchers using rats evaluated the effects of fixating joints over time. In as little as 2 weeks, adhesions had developed with intra-articular degenerative changes starting to appear. They concluded, quote, hypomobility results in time-dependent adhesion development within the Z-joints. Such adhesion development may have relevance to spinal manipulation, which could theoretically break up Z-joint intra-articular adhesions, unquote. And now a summary. All of these studies are helpful in framing our perspective on what we do as chiropractors, assuming we use an osseous form of adjusting. To understand that for the lumbar spine, side posture positioning itself may have added benefit to manipulation is important. The relationship of gapping to cavitation seems obvious, but is now confirmed in research. Velocity and temperature may be taken advantage of to facilitate the adjustment. We also now know that it is more common for multiple joints to cavitate with adjusting, and in the cervical spine, this occurs ipsilaterally as often as contralaterally. Taken together, it implies that specificity is likely not entirely attainable.